Thank you, Jamie, and thank you to the team and to all of you for joining us. I'm really excited for this conversation with Dr. Lisa Fitzpatrick. As Jamie said, she's a powerhouse in public health. She blends her expertise in infectious disease, medical epidemiology, and Medicaid leadership, and she empowers communities with accessible, no-nonsense health information. And she's the founder and CEO of Grapevine Health, which we're going to talk more about in a moment. Lisa, welcome and thank you for being with us.
Hi, good afternoon, everybody, and thanks for having me.
So to get started, I'm going to kick us off on a bright note. I want to know, why did you get into healthcare and where do you find joy in the work you do every day?
I got into healthcare because I was good with people. My mother told me I could be a doctor, and I think it's really important for young people to have someone in their life who can help them be aspirational like that. So when I applied to med school, I didn't know what I was getting myself into, but I knew I wanted to be a doctor, and it all worked out. And I've had a really incredible career, as you've heard. I've pivoted many times away from things that are your typical physician story. I never hung my own shingle. I either saw patients as part of a health system or federally qualified health centers, safety net institutions. And it's been really rewarding. What brings me joy now, though, is when I see the light bulb go on. And so what I mean is people are confused by health information a lot. And when I explain something to someone and they say, "Oh, I've never heard it like that before. Oh, well, thank you for helping me figure that out." That's really powerful for me. I have even had people text me and say, "Can you please log into my health portal and tell me what my X-ray report says, or I got a pathology report and I don't understand it. Can you read that for me?" It just shows you how desperate people are for information they trust. And so I would say that's what brings me the most joy right now.
That's wonderful. And so you mentioned trust and not knowing what you were going to get into when you got into medicine. So I'm curious about what some of your experiences have been that have led you to do this focused work on trust and building trust.
Well, people always ask me, why did you start Grapevine Health? And, it seems like such a crazy thing to do after all the things you've done and what you could be doing in healthcare. When I was at CDC, I was asked to be on a community panel for 100 Black men. And this panel had some really impressive people on it, like Dr. David Satcher, former Surgeon General, Dr. Lewis Sullivan, Kamara Jones. And after this panel was over, a man came up to me and he said, "How does someone like me access someone like you on a regular basis?" And I have never forgotten that, because he explained to me how he had a doctor. He was supposed to take medications, but he didn't understand what his doctor was saying to him, and he didn't trust that he needed to be on those medicines. And so I talked to him for a while, but I went home thinking about that, trying to figure out, how can we do a better job communicating with people so that they trust the information they're getting from the healthcare system. And that's why I created my video series, Dr. Lisa on the Street. And Grapevine has really just evolved from a series of experiences and encounters like that gentleman that have just weighed very heavily on me, that we are doing such a lousy job educating people about their health, because it builds trust to talk to people in the language they understand and they can relate to. And I think that's something we don't spend enough time thinking about across the health sector.
That's the perfect segue, actually. What I'd like to do is show everyone a quick video. I think it's like no more than 3 minutes of how I first met you. I think, was it 10 years ago when you started doing Dr. Lisa on the Street?
Yeah, it was.
Yeah.
My video was in 2013.
So let's put that up and show everyone Dr. Lisa in action.
doctors often speak in a language that people don't understand. Has this ever happened to you?
Pretty much all the time.
Oh,
Not cooking food properly.
That's salmonella.
Well, that's no.
okay.
And don't want one. I see everyone pushing it. They keep pushing it. And everyone keeps pushing it. I'm sick of corporate America pushing stuff up.
Sean got some Pop-Tarts.
Yeah.
Okay, didn't you just tell me that we have to cut down our sugar?
I did.
And you're a diabetic, and you have Pop-Tarts and Fruit Loops.
These are the kidneys or lungs.
You said kidneys are lungs?
Kidney or the lung.
So that's the kidney. This is the lung.
Hospital with her one day, and she wanted to say she was pregnant, but she said, "Oh, I got a stomach ache," something like that. So it depends.
You go to the emergency room and get a physical. So do you have
Sometimes
Yeah.
it all depends.
But how do you think we can get the message out to them?
The way you're talking to me now, each
Right.
one teach one and
Oh.
spread the news.
All right. I'm Dr. Lisa. I'll see you on the street.
How does it feel to watch those videos back now? Oh, you're on mute.
I love watching these videos. I mean, there's a universal nature of those conversations. Most of the people I've been talking to over the last few years have been people from underserved communities, Black and Brown communities. But before, I was talking to anybody who would talk to me, and it didn't matter what their background was. And a lot of the issues were the same. In the very beginning of the video, you saw I was talking to a white man, and he said, pretty much all the time, I don't understand what my doctor's saying. So when I watch the video, it just validates why I'm doing what we're trying to do, even though it's really hard and it's taking a long time to get traction. It reminds me that we're on the right track, or at least the mission makes sense.
Absolutely, it does. And that could be filmed tomorrow, and it would probably be very similar conversations.
Yeah.
And you said you're talking to people all the time. Like, what inspired you to just go out there, bring a video camera, like bring a model of a body? Like, what encouraged you or inspired you to start to do that?
So I have been described by some of my supervisors as creative and fearless. Now, I don't know about fearless, really. I don't feel like I'm fearless, but I do think I'm a creative person. And I'm not afraid to try something new or different. So when I first started going on the street, it was really unnerving. I actually didn't like it, but the conversations I had were so encouraging. I knew I had to keep going. But the reason they were unnerving is because we've all run into those people on the street who are trying to get you to stop and talk about something, or usually they're trying to give you money. So I have that going for me. I'm not asking people for money. But the challenge is, in the beginning, I had to probably stop 10 people and 2 would talk to me. When I got that organ model, and the reason I got the organ model is because I realized people have no idea what's inside their bodies and how these organs are related to each other, how they should think about symptoms and so on. These are things I learned in the conversations. And one day I need a visual. So what I learned from the organ model is that when you have a prop like that, you don't have to work very hard at all to get people to stop.
Yeah.
So my hit rate went up to about 60%, especially if there are kids around, because kids cannot resist coming over and touching the organ model. And then the parents will come behind, and there's a teachable moment there for them as well. So I just thought, well, we have to try this. Because the gentleman who asked the question, how do I find someone like you on a regular basis? Well, I couldn't clone myself. So what was the next best thing? Could I digitize my knowledge and really amplify what I was trying to help people understand through video?
Yeah.
And so in order to do that, I had to find a videographer, and I found Francis, and it was just the 2 of us. And we just went out to see what would happen. And the first video was on flu, and it turned out so well. I said, okay, we have to keep going.
Yeah, I mean, there's a scale model there of,
Mhm.
you know, how do I do this with more people? And I would guess if I was a clinician, my biggest question would for you, or my biggest resistance might be, I don't have the time to spend this time with my patients or to even have these conversations with people. Do you hear that a lot? And what do you say to them?
All the time. And even when I started Dr. Lisa on the Street, it was really my sort of side hustle. I was so passionate about it. I was working a, very demanding job. And I said, but I still want to do this on weekends and, evenings in the summer when there was a lot of daylight. But now I do give grand rounds now and then, or I give webinars for health systems sometimes. And this question comes up all the time. Yes, I know health literacy is important. I know I probably should do a better job, but these visits are so truncated. I just don't have time. And I push back on that because in that visit, we know the data show that physicians and care providers provide or give or spend most of the time in that visit talking rather than listening. So what are you saying? And is it, something simple that you can just tune in if you say, this is exacerbated by that, or the gold standard for this is, those are choices we are making in the way we communicate with people. And if we don't take the time to ask, the teach back method is a very important tool we should be using to make sure people understand. So if we ask people, tell me your understanding of what I just said to you. That doesn't take very long at all. So I think it's about prioritizing, not only prioritizing what you're going to cover in the visit, which I know is sometimes difficult. People come in with their long lists, but the way we respond to them matters. And so I think it's a lot easier for us as physicians in particular to talk in our medical language. It rolls off the tongue. It actually takes a bit to figure out how to translate some medical jargon into plain language.
Yeah.
And I remember during the pandemic, having a conversation with a well-known, well-respected researcher. And during this conversation about the vaccines, I asked him a question. And then when I circle back to say, can you say that in a different way, in like plain language? He had to think about it.
Yeah.
Because it's not second nature. We don't really focus on this in medical school to help people remember. Like, you're a person. Before you were a doctor and a medical student, you were a person and you spoke in plain language. So we need to continue doing that with patients. It's more important than ever.
Yeah, and I mean, there's a competency there, right? Because if you're trained in a certain language, there is probably some activation energy in learning this new language of plain language. But I love what you just offered, which is over time, probably a time neutral way of integrating more plain language into a clinical encounter, for example. Are there other themes that you've heard related to health literacy in these conversations, or themes around communication that could help kind of bridge that gap and build relationships?
Well, I think, we're talking about trust today. And I think it's really important for whoever is on a healthcare team to recognize the connection between trust, health literacy, and engagement in care. And the reason it's so important for us to recognize that is because we're always trying to figure out, well, how can we get people to better engage? Essentially, how do we get people to do the things we're asking them to do? Why are clinic visits, why are the no-show rates so high? Why are we challenged with medication adherence? Things like that. If you ask people, and we've heard this on the street, and I've also heard this with some of my own patients, what is the reason? It really gets down to, if you don't speak in a language I understand, I don't really trust you. And I had a gentleman tell me this at a homeless shelter. He said, you all sound like you're speaking in Greek. So if I don't know what you're saying, why would I trust you?
Yeah.
And so I think just things like that, we just have to remember, because we take it for granted. It's so easy for us to speak in this language. And I think it takes some practice.
Yeah.
And it takes some reminders. I have an example, though, to really bring this home, this connection between trust, health literacy, and engagement or outcomes. My neighbor has a heart condition. He's finally starting to admit he has a heart condition. But I saw him walking out in the community one day, and I said, "Where have you been? I haven't seen you in a while." He said, "Well, I was in the hospital." And I said, "What happened?" He says, "Oh, don't worry, I'm fine. They told me something was wrong with my heart, but look at me, I feel good. There's nothing wrong with my heart." And I said, "Well, why did you go to the hospital in the first place?" And he said, "Because I couldn't breathe." So I had to explain to him why his breathing and his heart are connected, and why the medications he was refusing to take help his heart condition and his breathing. And he said, "Well, they didn't explain it like that." And I don't trust those doctors, because they're always just trying to give you medicine so they can make money.
Yeah.
And so these are the themes, the trust. You can hear the distrust. Why are you giving me this medicine? You're not explaining it to me. There's nothing wrong with me. You're saying I have all these horrible things, but look at me. I'm walking and I'm talking. I can't possibly be as sick as you're saying. And so what happens is he skips the next visit because he feels fine. He leaves the medicine in the medicine cabinet because he doesn't feel like he needs to take it. And so this is the gift I've been given by talking to so many people about the nuances and the specific things that help them make a decision about whether or not they're actually going to go to their doctor visit or take their medicine. And I think it's the piece that's missing when we're jumping from people need to come to their healthcare visits to why aren't our outcomes improving? There's a lot in the middle there that I think we really have to focus on.
So it's the language we're using, it's also behaviors. You shared a story last time we were together about a banana. And I'm wondering if you could share the story with us. And, it relates to some cultural sensitivity and conversation, but there's more there. So I'm wondering, could you tell us about it?
Yeah, people love this banana story. It's fascinating to me. I mean, I have a lot of stories, but that's the one people always remember the most. So I was out in the community. This was actually during the pandemic. And for us, we felt it was really important to show up in the community so that people could see we're trustworthy. And we're here for you. See, here we are in your community. So we have a table set up with all sorts of things, including the organ model. I think we were taking temperatures and some other things we were doing, giving out masks, answering questions. And there's a woman who keeps walking by, and I can tell, even though I'm talking to other people, I can tell she wants to engage, but she doesn't. So she disappears, and the next time I see her, she is walking across the street with 2 bananas, one of which she's eating. And she walks over and gives the other one to me and says, "Here, I bought a banana for you." And I was really touched that she gave me a banana. I thanked her and I put the banana in my pocket. And she said, "Oh no, I want you to eat it." And I said, "I am going to eat it. It's a great banana. It doesn't have spots. It's just like I like my bananas." She says, "No, I want to watch you eat it now." And I paused for a second and I said, "Well, tell me why it's so important to you that I eat this banana right now and I'll take a bite." And she said, "I want to see if you trust us." And in that moment, I felt really small, because I was really focused on me presenting myself as a trustworthy person to the community. But from her perspective, and probably lots of others' perspectives, they want to know, well, do you see me as equals? Do you see us as equals? Do you trust us enough to listen to what we're saying? Are you going to be condescending? Are you going to listen to what I have to say? She was showing me her humanity and demanding that I show her mine, right? So it's a really powerful story for all of us, because this is a two-way street. It's not just about building trust, but it's also about being trustworthy and being perceived as being trustworthy. But that even is bi-directional. It's not just, am I trustworthy, but do you see the person you're helping as trustworthy? Because in healthcare, I did talk to her a little bit more, and her perception is that people don't listen to her. And when she tries to tell them what's going on, they don't believe her anyway. And so that's broken trust right there. And I think we do it a lot. I'm sure I've done it many times in healthcare, because I think I know, when people start telling me their symptoms, I'm already forming my differential diagnosis, and I already have landed on something. Okay, I think it's this or this, but they think it's something different. And so it's my responsibility to listen, but they pick up on these cues.
Yeah, like you're waiting for them to finish talking, and because you already have their diagnosis.
We've also asked people, how do you decide you trust your doctor? And listening is the most common thing we hear. But a woman gave me a visual. She said, I know it's time for me to stop talking when my doctor moves toward the door and puts her hand on the doorknob.
Yeah.
And I was thinking, well, how many times have I done that? It's like I'm wrapping up the visit before the person's
with
really
your body.
done. And I think that it's just, these are, again, the subtle cues people pick up on from us to know whether or not they can trust us or if we're listening to them.
Well, I'm glad you talked about the bi-directional nature of trust. You also touched on trustworthiness, not just trust, not just trying to seek trust, but making sure that you're actually worthy of the trust you're seeking. And I think I feel really compelled by the banana story, because my reaction every time you tell it is like, I'm worried for you. I'm worried that she's done something to the banana. I'm worried that she's trying to hurt you. And I think that, especially after the election, we're more polarized than ever. There's fear on both sides. And I wonder the extent to which that plays into some of this dialogue. And do you have any reactions to that? Have you seen anything change in the last week?
Well, okay, so two things. I'll cover the election second. Your reaction to the woman offering me a banana, I would say it's pretty much the universal reaction, but it wasn't mine. I had no hesitation about eating her banana. And it's interesting to me that I didn't. I'm not sure why. I think it's because I'm so comfortable being in this environment, and I have an intuition. And I think a lot of, there are safety concerns with some of the communities we go in, but after you've been there a while and you know the rhythm, you can spot harmful things, or, your spidey senses will go up when you need to either move on or move to a different location or just leave altogether. And none of that was coming up with her, because I could tell by her body language that she really she needed something. But there was something hindering her from interacting with me. So, and I just want to ask, people who have that initial reaction, why? Because I think we are on edge. We don't know who to trust, and we don't know if someone means us harm. But this is carried over into the healthcare system, and it's a really murky time right now, because there has been a lot of harm to healthcare providers or people working in healthcare who are trying to help people. They have encountered violence, and it's not okay. But in this situation, I had no hesitation about it at all. With the election, though, and I have furiously been reading Twitter more than I ever have. And now my feed, because that's how the algorithm works. If you look at a couple of things more than once, or you linger a little bit, then your feed completely changes. My feed used to be public health, infectious diseases, funny animal tricks. And now it's all politics. And so what I'm noticing is a bit disturbing to me, and that is, people aren't listening to each other even more than before the election. And I think it's really only going to magnify in the years ahead, and it concerns me. I also am seeing a lot of people who are very disconnected from reality when it comes to their healthcare and their vote. And my example of this, I see it on Twitter. I've seen it since the election, but I had a personal example of this, and I posted about it on LinkedIn. Part of what we do at Grapevine is we try to introduce people to digital tools that might help them navigate their health. And so in this case, we have some access to CGMs, continuous glucose monitors. And we've been trying to introduce this technology to people, whether they have diabetes or pre-diabetes, to help them see, here is a tool that can really give you a lot of information about your health and help you make some changes. I used to see Jim, and it really motivated me to change some things in my diet. So this gentleman was really receptive. And I asked him, because he said, I really need to find a good doctor. And part of our role is to try and help point people to the healthcare services they need. So I gave him a CGM, met with him, we talked about his food. And then I said to him, I would love to go with you to one of your visits. So, and I just did this as an experiment. This is not something we generally do, but I was really curious because he was talking about how he didn't understand anything about diabetes, but he'd already had 2 clinic visits. And I was trying to figure out, like, where is the disconnect? So we're sitting there waiting to go to see the doctor. And I said, so how do you feel about the election? He's like, oh, I'm happy. I voted for Trump. And I said, oh, why? Why did you vote for him? He said, well, I know he lies, but you just don't have to figure out what he's saying. He's direct and he's to the point, and, he's just straight to the point. And I said, oh, well, you have Medicaid, right? He said, yeah, I got Obamacare. And I said, did you know that Donald Trump and the Republicans have tried multiple times to overturn Obamacare? And if they're successful this time, you might not have health insurance. And he said, oh, well, no, I didn't know that. And so it just points out to me how important it is for us to really think about how we're communicating about these things, especially now, because there's going to be a lot of misinformation and people speaking on authority about things they know nothing about, which is my concern about the potential folks who are going to be running our health agencies. There's some chatter about who might be running these health agencies. And so I felt compelled to write a thread about vaccines because COVID vaccine aside, people seem to have forgotten. The reason you don't hear about polio and the reason you don't hear about, epidemics or outbreaks of meningococcal sepsis and pneumococcal sepsis is because we have vaccines.
Yeah.
And so before the pandemic, people seem to have trust in vaccines and what, their physicians were recommending around vaccines. And I think it's going to be even more important for all of us to speak out about what we know. Yeah. I realize COVID has really done a lot of damage for our sector, but we have to remind people that sure, there were some adverse events associated with the COVID vaccine, but you can't discount all the lives that have been saved over decades. And so I think speaking, through stories and just in real plain language about this to help people, because I'm nervous about what's going to happen to people's healthcare if they overturn the ACA and people have no idea. Even if they don't know what kind of health insurance they have, they don't know who to call when they have a question. And it's going to be really challenging for a lot of people, including in red states. And so that's what I'm really concerned about.
Yeah. Yeah. And you spoke about this with your algorithm, but the information environment is now a social determinant of health. Where we get our information is influencing our behavior in really important and consequential ways. So you've mentioned it a few times now, but could you tell us more about Grapevine and what you do there and how your organization kind of strengthens this information environment?
Well, we're at an inflection point with Grapevine, just to be honest. And the reason is because all the things that you hear me so passionately talking to you about are not necessarily the things we are optimizing for right now, because most of our work is with insurance companies.
Oh.
And Grapevine Health is a social impact for-profit company. It is not a nonprofit. And so because we work with insurance companies are still trying to figure out how to work with startups. And so even though we've had some engagements with insurance companies, there are millions of people across the country who need what we're doing. So we have 8 to 10 other physicians now, Black and brown. So we have 5 or 6 Spanish-speaking physicians as well. We need to be creating the kind of content that will scale to where people are actually consuming content on social media, on televisions, when people are sitting in, waiting rooms like the ER and the doctor's office. That actually has not been where we've been focusing our attention, but now I feel some urgency around the need for us to figure that out, because people aren't getting access to Grapevine content on the scale we really think people need it. But the simple answer to your question, what is Grapevine? We are, I call us a digital health media company, because we use videos, we use content to capture people's attention and then get them to link to whatever a service is. So to close a care gap for payers and insurance companies, this is what they care about. How do we close the care gaps? How do we get more people to get their colon cancer screenings? How do we get more kids to get their physical exams every year and their vaccines and so on? But that's not necessarily what people want to hear about. So that's the inflection point for Grapevine. Do we continue down this path trying to work with payers, knowing that we really need to try and reach the masses, because people are just hungry for trusted, relatable information, especially from Black and brown doctors. It's just how it is, which is hard to hear. And we've had a lot of feedback about that too. But we are dedicated to the Medicaid population, because we don't see enough organizations working there because they don't think there's money there, but there's definitely a need there. So happy to answer more questions about Grapevine if necessary, but that's kind of the overview.
Yeah, thank you for that. And I know Jamie or Amberlyn put a link in the chat for you if you want to look at more about Grapevine or watch any of the Dr. Lisa on the Street videos. You authored a piece in Forbes recently about trusts and asked if it was too big to fail or too big to fix. And you came out an optimist in the end. And I'm wondering, are you still feeling that way today?
Yeah, absolutely. It is too big to fail, because trust is linked to so many things. So let's take healthcare out of it. If you're going to go buy a car, or let's say you have a car, you love your car and your car needs service, where are you going to take it? How do you decide if you're going to take it there? Do you want to be fighting about whether or not you were overcharged or not? And so trust is ubiquitous for all of us, all the time, every day. Any decision we make, there's some level of trust that goes into that decision. And so it's no different for healthcare. And so back to the guy's comment, if I don't understand you, I don't trust you. So there are so many conversations right now about how we improve healthcare. How do we scale value-based care? Well, what is value-based care, and how much are we considering what people want and what it takes to get them to engage in these value-based care models? The outcomes, we've been looking at embarrassingly poor health outcomes for decades. We're still here. So we have to start asking some of these questions about, okay, what's really going on? And I think the more we talk to people, the more we'll come to understand it. But I'm not naive to think that there is a policy solution. We're desperate for a better policy solution here. And that so many of these solutions rely on proper reimbursement or some mechanism to support them. Like, why don't we focus on prevention? People see that all the time. That's why they call us drug dealers. I don't know if you know, but I did a class at DC Improv, 5 minutes of funny. So I did a 5-minute stand-up routine. And the funniest joke, the funniest part of the routine the audience seems to respond to is when the guy tells me he doesn't trust doctors because we're drug dealers, because all we do is prescribe medication. And when I get him to come and see me, because he wants to come off of his medication, I tell him all these things he has to do in order to stay off the medicine. And then he asks me for a pill. So again, it's communication. How are we communicating? It's trust. And trust feels like a trite word. Everybody's sort of throwing it around. But I think we each have to give it meaning. What does it mean for each of us? And how are we going to interrogate what that means so that it makes sense for us? For me, trust is all about communication. Because you can't build trust with anyone if you don't connect with them by communicating with them.
And you've said this several times now that people need to take trust seriously. And so if I'm a leader of a health system listening right now, what can I be doing? Should I be doing to be building trust with the patients I'm seeking to serve or the communities?
It all sounds really trite when you say you have to listen to people, but that's what it is. So to make this more concrete, because I have been asked this question, probably no exaggeration, hundreds of times, 2 things come to mind. So at one of the safety net hospitals I was at, the hospital was falling into bankruptcy, and they brought in a consulting firm. And the consulting firm listened to the staff, the doctors, and came up with a list of action items. And one of those was we have to engage the community and listen to the community. Do you know what they did to check that box? They made some flyers and they sent them out to some of the organizations that were associated with the hospital. They picked the date and the 2-hour window when the community could come to the hospital so the C-suite could listen to the community. There's so many things wrong with that approach. The second thing is, and I do a lot of listening and feedback sessions for some pharmaceutical companies who are trying to increase minority participation in trials. So this question comes up in kind of a different way, but I think it's true across the board. When we think about engaging community, we go to these organizations we trust. And these organizations might be advocates who speak on behalf of community, or they have built trust in community. Those organizations are really important to hear from, but it is not a substitute for listening directly to people. And the final thing I'll say on this, it's hard for me not to be honest when I'm talking to you, Jess. So I have had a C-suite leader tell me, well, we have to be careful what we ask people, because then they'll expect us to do something about it. Absolutely. See, no one wants to say that out loud, but I think there is some component of that. You know, is there some accountability that comes into play when you ask people, well, what would make you stop going to the emergency department? Well, if you could have primary care visit appointments available on nights and weekends so that I don't have to take off work. How many times have health systems heard that feedback, or they know that intuitively, but it still is not happening? And this is why people feel like they're not being heard, which leads to, it deepens the distrust. So
Yeah.
I
Earned
think
mistrust.
there are lots of lessons that healthcare leaders already have heard or they know, but it's just really hard to implement for a variety of reasons.
Yeah, so for a variety, I will say, of compelling reasons, financial reasons. So, they feel their hands are tied. But I think what you've shown me, at least throughout the course of this conversation, is that there are small things you can do, that there's more in under your control than is not. And you have to start by asking.
Well, I think C-suite leaders can be more curious, more open, less risk averse to have these conversations and become an advocate if they really believe they can improve outcomes and they can improve access even on a small scale for people who aren't getting the care they need. Maybe they can educate. C-suite leaders have to go, especially at city-owned hospitals, even though they're vanishingly small number now, but educating the lawmakers about these challenges. Again, it's back to how are we communicating this information? Because they don't understand the intricacies involved in running a health system or, a series of community-based health centers. And so, but sometimes we're afraid, right? We don't want to bring that up because if you open that can of worms, does it create a whole series of other problems? And so at some point, I think you just have to make a decision and take a stand and say, I'm going to try this.
Yeah, yeah. And certainly there are C-suite leaders who are and who do it. I think it's that time to go to questions. Jamie, has anything come up in the chat?
Not yet in the chat. So if you do have a question, feel free to type it in or raise your hand. But we did get a few questions that were pre-submitted during registration. So one of them asks, how can the state health insurance exchanges help? I work for the state health insurance agency, one of them that was created through ACA. We know our customers have trust issues that make them less likely to seek preventative or acute care.
Well, the exchanges, I think, first have to make sure people can access the sites easily. And there are a lot of technical considerations there. We've talked to people about why they don't use their health portals. And it usually comes down to things like, well, I can't keep up with my password. When I get in there, it's too many clicks. I don't really know what to do. I get confused. And so that's one way. Is there some way to ease the burden, the technical burden on people who need to use it? But I think a lot of the exchanges have done a good job finding navigators to help people, but somehow not everyone's getting the message that this support is available to them. So maybe there's some way they could better communicate access to these helpers who can help people navigate the portals. And then, of course, which will sound very self-serving, but I think they could benefit from some video education. People are consuming information and getting information through content, through videos, short posts. It's not the world of 2000.
You got to get on TikTok.
Not just TikTok, right? It's Instagram, Facebook, even YouTube. That's where people are getting their information. It's a hard pill to swallow, but we've got to do better. We want to get this information in front of people. You've got to put it where they're already paying attention.
Not a question, but a comment in the chat that I just want to make sure that you see. Lisa from Heather Mitchell said there's also a need to remove the pressure from the patient to have understood what was communicated when teach back is used, put the responsibility on the doctor to explain clearly so they could say to the patient, I want to be sure that I did a good job of explaining myself. So could you share with me what you understood from our conversation? And that got a lot of love from others in the audience.
Yeah, I absolutely agree with this. I became attuned to this concern a few years ago when I was carrying on about health literacy, and someone said, well, I think that is a really condescending term, and we should stop using the term health literacy and find another way to talk about this. And just trying to understand why, like, what's wrong with this term health literacy. That was her perspective, that we tend to blame people for having low or limited health literacy when it's actually our responsibility. And so that's generally how I talk about it, because I spend so much of my time talking to healthcare providers about how we're communicating. I wholeheartedly agree with that. It's a culture that needs to shift, though. And we're not there yet.
Thank you for that. And another question that we received pre-submitted, this person wrote, as someone with complex chronic illness, how do you build and maintain trust with rotating door providers? So they're asking how they can build better trust.
Yeah, that's a hard one. I certainly don't have probably an adequate answer for that, because first of all, the person needs to have the resources available to know how to respond and engage and be able to adapt in that situation. And I think we don't really have great resources for people other than to say, you know, write your questions down, you know, get prepared for your visit to try and maximize the time. But when people get in the room, it's really challenging. So yeah, this is a good question, but I don't have a great answer for it, because I think it's so situational. But I also think that one consistent thing people can do is to speak up when they don't understand what's being said, because too often that's not happening. We've had folks say, well, I didn't realize, you know, the doctors are so busy, I don't want to bother them, or I didn't know I could ask follow-up questions. So, and I don't want to offend the doctor. And so I think these are things that we can give people permission to say, no, this is about you. It's not really about us. But that's a great question. Thank you.
And now I'm seeing a ton of activity in the chat. I'll go to the top. Carrie asked if you could speak to using health coaches to work with folks to self-advocate, like the Coleman model in care transitions.
I love anything akin to a navigator, a community health worker, a coach. I think these are really powerful. And also there are data to support the need for these and the outcomes associated with them. The one area I think could use improvement, particularly among community health workers, is just helping them to understand how to use the information they're hearing. And this is also very situational and a bit difficult. I used to have a really good example for this. It was about a community health worker who did a home visit. And when she came back and reported what she saw, I said, oh, well, did you ask this and this and this? She says, oh, I didn't know to ask that. And I wish I could remember the example, because it would really bring it home for you. But the idea is, we can't just say, well, because you come from the same zip code and you have the same skin color, you're going to be a great community health worker for these people.
Yeah.
That gets you so far, but we also have to arm them with the skills and the intuition to know when they're hearing valuable information that can be fed back to the clinical team. But I love these healthcare extenders. I think they're critically important.
Another question, the foundation has been looking into how medical debt hurts trust. Have you found in your work and during your conversations with people on the street that medical debt comes up as a factor that affects trust? Do you think that physicians should be able to talk to their patients about cost?
Well, first I'll say physicians don't want to touch this topic because it's such a taboo subject. And many don't think it should come into the clinic room or the hospital bedside. But yes, emphatically yes. So remember what I was saying about doctors being drug dealers? The whole reason people think this, and I know it's, again, if there are any doctors listening, I know it's really hard to hear, but we have to listen to not necessarily those words, but where is that coming from and what does it mean? It's about the optics. I came in to see you. You didn't listen to me, but you gave me 3 prescriptions. Some of these I can afford and some of these I can't. You're making money. And so when people are saddled with debt, they see a system that doesn't care about them because they may still feel sick, but now they have a lot of debt. And so why would they trust that the healthcare system is really there looking out for them? So yes, we've heard this in a variety of ways, but it all means the same thing, that the healthcare system is really driven by profit and money. And I'm second as a patient. It's not about me, it's about them making money. This is a hard one.
Yeah. Why is it taboo? Why don't we want to talk about it?
Well, I don't want to talk to my patients about money. I really don't. I mean, if they ask me, we can have a conversation about it, but I don't really have an answer because I'm embarrassed that our healthcare system is really, some of these things I probably should not be saying in public, but why not, Jess? It is an embarrassment to me that people can't get the preventive services they need, but we wait for them to get sick. And then that's when the money starts flowing to pay providers, right? So people see that. We forget about the optics. We're inside and we're just doing our jobs. But on the outside, how does it look to people? Well, I can't go there. This is why people delay care because they're afraid they're going to get a bill. We were doing outreach a few years ago, and we went through this homelessness encampment. And this guy comes out of his tent and he says, "Are you a doctor?" And I said, "I am." He goes, "Can you help me with something?" And he runs back and he brings out a bill, or so he thought was a bill. He said, "They keep sending me this. Can you look at this? I can't pay this bill." It was actually an explanation of benefits.
Oh,
But he was carrying this paper around for months because he was terrified that someone was going to come after him because he didn't have the money to pay, and they keep sending it. And so I think we just really have to do better helping people understand, whether it's the doctor. I think doctors can talk about ELB. Something like that would probably be very, very easy for us to talk about. But people really don't want to come in and talk about their bills either and whether or not they can pay. And they just don't come. They vote with their feet. And that's why they're so sick when they step on the doorstep of the ER, because they were afraid, they were trying to avoid the cost. So yes, whoever asked the question,
yes, Kim.
unequivocally, yes, it influences trust and willingness to engage.
You got an amen in the chat. And it looks like, is there another question in here, Jamie?
There's a comment from Uzma. One of the things I notice with my providers is that I'll bring something up about a treatment that I might not resonate with and ask for other culturally mindful ways to symptom management. But so often it becomes a conversation about, well, you don't have to receive treatment here. And she said it, or they've said it feels like a conversation takes a very personal turn instead of turning collaboratively to looking at other treatment options.
Do you remember the banana story? That's what that is. So not even being willing to engage in a conversation or to consider that medication might not be the best thing for this person. And this, again, feeds into the optics I was just talking about, how people are perceiving doctors and pharmaceutical companies are working together. I'm asking, is there some non-pharmaceutical intervention you could do here? And you're saying, you're either being dismissive or you're saying, no, but here's a pill, right? So we know people need medications and they will continue to need medications, but it's about how we communicate about the need for those medications. And we also need to appear open and feel open to people being able to express concerns about taking medications. Like in this case, I think that is a really great question. Thanks for pointing that out.